Hello, ladies and gentlemen. Our public health education program new subject is small bowel cancer and appendiceal tumors. Small bowel cancer and appendiceal tumors. Small bowel cancer is a rare malignancy representing approximately 2% of gastrointestinal neoplasm. In 2009, it was estimated that 6,230 new cases of small bowel cancer and 1,110 small bowel cancer related deaths would occur. Most cancers of the small intestine are adenocarcinomas because of the non-specific clinical presentation of small bowel adenocarcinoma and the difficulty in imaging the small bowel. Most patients with small bowel adenocarcinoma present with lymph node involvement or distant metastasis, even in patients with localized disease who undergo resection with curative intent, the prognosis is poor, and no studies have yet demonstrated a clear benefit from adjuvant therapy. However, there have been some recent advances in the use of chemotherapy as palliative treatment. In this chapter, the epidemiology, diagnosis and treatment of small bowel cancers, in particular small bowel adenocarcinoma, are received. Epidemiology. Based on an analysis of the surveillance, epidemiology and end results database, the age-adjusted incidence rate for small bowel cancer has slowly increased from 0.9 per 100,000 persons in 1973-1982 to 1.8 per 100,000 persons in 2004. The majority of this increase has been attributed to an almost threefold increase in the incidence of carcinoid tumors. Among the 14,253 cases of small bowel cancer diagnosed between 1985 and 1995 in the American College of Surgeons National Cancer Database. 35% were adenocarcinomas, 28% were carcinoid tumors, 21% were lymphomas, 10% were sarcomas, and 6% were other histologic types. The incidence of histologic subtypes varies in the different sections of the small intestine, with adenocarcinomas representing 80% of duodenal cancer and carcinoid representing 60% of ileal cancers. The incidence of small bowel adenocarcinoma peaks in the 7th and 8th decade of life with a mean age At diagnosis of 65 years, a slightly increased incidence is seen in men and blacks. One of the more interesting aspects of small bowel adenocarcinoma is its rarity in comparison to large intestine adenocarcinoma. Even though the small intestine represents approximately 70 to 80% of the length and over 90% of the surface area of the alimentary tract, the incidence of small bowel adenocarcinoma is 30-fold less than the incidence of colon adenocarcinoma. Numerous theories have been proposed to explain the small intestine relative protection from the development of carcinoma. Proposed protective factors have centered around two concepts. First, the rapid turnover time of small intestinal cells results in epithelial cell shedding prior to the necessary acquisition of multiple genetic defects. Second, the small bowel's exposure to the carcinogenic components of our diet are limited due to the rapid small bowel transit time, the lack of bacterial degradation activity that occurs in the small bowel, and the relatively diluted alkaline environment of the small bowel. Anatomy and etiology. Little is known about the etiology of small bowel adenocarcinoma as seen in colorectal adenocarcinomas. Adenocarcinomas of the small intestine undergo a similar phenotypic adenoma carcinoma transformation. An increase in the size of small bowel adenomas and the presence of villous histology are risk factors for the development of invasive adenocarcinoma. Common underlying genetic or environmental factors of both large and small intestine adenocarcinomas have been suggested by studies that have demonstrated an increased risk of small bowel adenocarcinoma in patients with colon adenocarcinoma and vice versa. In small bowel adenocarcinoma, microsatellite instability occurs at a similar rate to that seen in colorectal cancer. In a study of 89 patients with small bowel adenocarcinoma identified from a Swedish population-based cancer registry, the rate of microsatellite instability was 18%. This result, along with the known clinical association between hereditary non-polyposis colorectal cancer syndrome and small bowel adenocarcinoma, indicates that in the subset of patients with small bowel adenocarcinoma, a germline mutation in one of the mismatch repair proteins contributes to carcinogenesis. The possible role of pancreaticobiliary secretion in the development of adenocarcinoma of the duodenum has been suggested by the anatomic clustering of duodenal carcinomas in the periampullary area, for example in patients with familial adenomatous polyposis. 80% of small intestinal adenocarcinomas will occur in the second portion of the duodenum. One study evaluating 213 cases of duodenal carcinomas identified from the Los Angeles County Tumor Registry determined that 57% of the cases originated in the second part of the duodenum. Environment and dietary risk factors. A number of case control studies have analyzed the association between environmental and dietary factors and the development of small bowel adenocarcinoma. Two studies have demonstrated that there is an association between the ingestion of smoke or salt-cured foods and the development of small bowel adenocarcinoma. An association between tobacco use to cancer risk has also been demonstrated in two studies, but other studies have suggested there is not an increased risk of small bowel adenocarcinoma with tobacco use. Other case control studies have demonstrated an association between an increased risk of small bowel adenocarcinoma and high alcohol intake, high sugar intake, high red meat intake, low fiber intake, celiac disease, peptic ulcer disease, and prior cholecystectomy. Studies on the relationship between obesity and small bowel adenocarcinoma are conflicting, with some showing increased risk and others showing decreased risk for obese patients. Genetic cancer syndromes, inflammatory bowel disease. Clinical presentation. The symptoms associated with small bowel adenocarcinoma are non-specific and frequently don't occur until advanced disease is present. The most commonly reported symptoms are abdominal pain, 45-76% of patients, nausea and vomiting, 31-52%, weight loss, 22-29%, and gastrointestinal bleeding, 8-34%. Delays in diagnosis are common, with one retrospective study reporting a mean delay of 7.8 months from the time of initial physician evaluation until a final diagnosis was made. According to the National Cancer Database, 39% of patients present with stage 1-2 disease, 26% present with stage 3 disease, and 32% present with stage 4 disease. Diagnosis, staging and prognosis, treatment, surgical management, adjuvant therapy, pattern recurrence. Metastatic disease. Appendiceal tumor, appendiceal discal tumor encompasses a rare and diverse group of neoplasm with an age-adjusted incidence of about 0.12 cases per 1 million individual per year. Appendiceal tumors represent only 1% of colorectal cancer diagnosed each year in the United States. Historically, appendiceal tumors have been grouped together with colorectal cancers. However, appendiceal tumors in which outcomes are strongly determined by histologic subtypes tend to have a biology very different from that of colorectal cancer. Appendiceal tumors comprise two types: appendiceal carcinoid tumors and appendiceal epithelial tumors. Appendiceal carcinoid tumors account for approximately 50% of all appendiceal neoplasm, and appendiceal epithelial tumors represent the remaining 50%. This chapter on appendiceal tumor will discuss the management of these two tumor types, carcinoid and epithelial, and in particular the unusual clinical syndrome of pseudomyxoma peritonei. Incidence, presentation, and prognosis. Incidence data derived from the surveillance, epidemiology, and results SCEER database of National Cancer Institute between 1973 and 1998 revealed that the most common histologic subtypes of malignant tumors of the appendix were adenocarcinomas 67% and carcinoid 33%. However, this analysis captured neither adenomatous tumor nor benign carcinoid. The subtypes of adenocarcinoma were mucinous type 56%, non-mucinous intestinal type 38%, and cyanide ring cell type 66%. Alternatively, in separate study of 7,970 appendectomy specimens, tumors were identified in 1% of specimens, with carcinoid representing 57% of all tumors identified. Adenomas and adenocarcinomas represented 18% and 11% of the identified tumors, respectively. Presentation and prognosis. The majority of appendiceal tumors are identified incidentally at the time of pathological review of appendectomy specimens. Symptoms of appendicity are most often the presenting symptom, especially with tumors located at the base of appendix, where obstruction is more likely to occur. Other symptoms seen with more advanced appendiceal disease can reflect the non-specific abdominal symptoms associated with peritoneal involvement, abdominal pain and distension, altered bowel motility, and early satiety. Metastatic carcinoid tumor may also present with symptoms related to the carcinoid syndrome, with episodic flushing, wheezing, and diarrhea. Patient age at presentation differs depending on the histologic subtype of the tumor, with the mean age of patient with carcinoid tumors of 38 years and the mean age for those with adenocarcinoma of 60 years. Pseudomyxoma peritonei, or false mucinous tumor is a term originally described by Werth in 1884, who described the pathological finding in the patient with rupture ovarian cystadenoma who had copious gelatinous intraperitoneal acid test. This term has been applied broadly to include any mucinous tumor type involving the peritoneal cavity with any histologic grade of differentiation. Treatment: cytoreductive surgery, hyperthermic intraperitoneal chemotherapy, systemic chemotherapy, and so on. Colorectal cancer, new one. Colorectal cancer. Colorectal cancer is a major cause of cancer-related mortality in the United States and many other regions of the world. It is currently the second most common cause of cancer death in the United States. For men and women combined, nearly 150,000 new cases and 50,000 deaths each year, accounting for about 10% of cancer mortality. The incidence of colorectal cancer declined by 2.1% between 1992 and 1996, and current data suggest that mortality rates may also be declining. These trends may be attributable to increased screening efforts, early intervention with prophylactic polypectomy, and improved adjuvant therapy. This has encouraged further research in prevention, detection, and treatment of colorectal cancer. During the recent past, investigators from a variety of disciplines have made important discoveries in the areas of carcinogenesis, screening and prevention, and anti-cancer therapy over time. These advances should contribute to continued reduction in the overall incidence and mortality of colorectal cancer. As an example, standard therapy for stages 3 and 4 colorectal cancer, which remain stagnant for many years, has continuously evolved since 2000. The number of drugs and drug combinations available for treatment and prevention has continued to grow and now includes targeted agents. This chapter reviews our current understanding of colorectal cancer, describes the known genetic mutations and risk factors, and outlines emerging screening, prevention, and therapeutic strategies, with particular emphasis on the approach taken at the University of Texas MD Anderson Cancer Center. Epidemiology and etiology: colorectal neoplasia, geographic distribution. Colorectal cancer is more common in Western industrialized countries. United States, Canada, Scandinavia, Northern and Western Europe, and New Zealand. than in Asia, most of South America and Africa. Since 1978, colon cancer mortality has declined in some Western European countries and in the United States, while the incidence and mortality rates for colorectal cancer continue to rise in Japan and China. Individuals who migrate from known low incidence regions assume the colon cancer risk of their adopted country implicating interplay of environmental and genetic factors in the development of this disease. The age-specific incidence of colorectal cancer in the United States rises steadily, with more than 90% of cases diagnosed in a patient 50 years of age or older. The male-female ratio for colon cancer is 1.34, while the ratio for rectal cancer is risk factors. General risk factors for the development of colorectal cancer include genetic predisposition, environmental factors, and accurate risks. These factors are involved in the stepwise progression from normal colonic mucosa to the adenomatous polyps to invasive adenocarcinoma. The neoplastic process often develops in individuals who have accurate somatic or inherited genetic germline mutations, which are promoted further by environmental, dietary, or other less well understood factors. Personal or family histories of colorectal cancer or polyp, older age, and inflammatory bowel disease have all been associated with an increased risk of colorectal cancer. Other possible risk factors include sedentary lifestyle and diet high in fat, low in dietary fiber, or deficient in specific micronutrients. Cigarette smoking has been implicated in the formation of colonic adenomas and carcinomas, with the relative risk correlating with total exposure and duration of smoking. Diet. Some studies have shown that the Western diet, rich in saturated fat, is associated with an increased risk of colon cancer, whereas a diet that includes a higher proportion of fruits and vegetables seems to protect against colorectal cancer. Dietary fat has been shown to promote tumors in animal models of colorectal cancer. A high-fat diet may alter the colonic flora, leading to a predominance of anaerobic species. Certain enzymes capable of metabolizing procarcinogens to overt carcinogens are present in higher concentration in the large bowel. It should be noted that the role of dietary fat has not been firmly established, and some studies have failed to demonstrate that high-fat diet is associated with an increased risk of malignancy. Fiber may provide a protective effect by decreasing the concentration of fecal carcinogens and decreasing fiber may be provide the protective effect of decreasing the concentration of fecal carcinogens and decreasing their transit time, thus reducing the period of exposure to colonic mucosa. Some studies have suggested fresh fruits and vegetables are protective Mediterranean style. Huge amount or rich fruits and vegetable meals. Very important because antioxidant and some essential trace element inside these plants, fruits and vegetables. Protective, although whether this effect is due to the fiber content on the presence of other protective micronutrients and antioxidants remains unclear. Moreover, the protective benefit of fiber micronutrients or antioxidants has not been consistently demonstrated. The Nurses' Health Study, a prospective study of 88,757 women aged 34 and 59 years, found no association between fiber intake measured in grams per day and the risk of colorectal cancer after a median follow-up of 16 years. Obesity. While diet rich in fat or low in fiber have long been implicated as risk factor for colorectal cancer, more recent analyses have suggested that an increased body mass index and in particular central obesity is a risk factor for colorectal cancer. Data from the Framingham study found that body mass index greater than 30 increased the risk of colon cancer by 50% among middle-aged 30-54 years individuals and by 2.4-fold for those aged 55 to 79 years. Of note, waist circumference was actually stronger predictor for colon cancer risk than body mass index. The link between obesity and colon cancer is not fully understood. However, insulin and leptin, an adipocyte-derived hormone, have been proposed as possible factors increasing cancer risk. Adenomatous polyps. Inflammatory bowel disease, familial syndrome, and so on. Continue. Some different screening for colorectal neoplasia, fecal occult blood testing, sigmoidoscopy, air contrast barium enema, computer tomography, colonography, virtual colonoscopy, genetic testing and counseling, molecular diagnostic, and so on. Just physician and doctors subjects and very deep detailed. Clinical presentation. Among the malignancies that occur in the colon itself, 60 to 70% of sporadic colorectal cancer are left-sided, whereas inherited colon cancer occur mainly in the right colon. Left side colorectal cancer are often associated with change in bowel habits, constipation, small caliber stool, fecal infection, or obstructive symptoms. Right side lesions are often associated with vague, abdominal pain, and bloating, acute or chronic gastrointestinal bleeding or bowel obstruction. Colonic lesion in any location can cause bleeding, which may manifest as melena, hematoschisia, positive hemoccult testing, or iron deficiency anemia, weight loss, anorexia, and other constitutional symptoms are particularly concerning as they may reflect the presence of metastatic disease. Any unexplained iron deficiency anemia should prompt an evaluation of the gastrointestinal tract. Patients may attribute their symptoms to other causes such as hemorrhoids, aging, or irritable bowel syndrome and delay medical evaluation. Conversely, primary care physicians unaware of the overall incidence of colorectal cancer may attribute signs and symptoms to benign condition, and several months may elapse before more intensive diagnostic procedures are performed. A delay in diagnosis may have serious consequences for the patient. Providing information to the patient and their family members about the lifetime risk of colon cancer and the current recommendations for screening is highly encouraged. Staging studies, pathology. Yes, and last, summary. Over the last 30 years, significant advances have been made in understanding the pathogenesis of colorectal cancer. Important risk factors, both accurate and genetic, and strategies for screening and prevention. Applying this knowledge should contribute to continued reduction in colorectal cancer mortality in the future and expanded array of biologic agents currently being investigated in phase 1 to phase 3 trials in the advanced disease setting. Many of these trials include the option of tissue or blood correlative in the hopes of better understanding the mechanism of action of these agents. Hence, patient enrollment in clinical trials is highly encouraged. Overall, given in the increasing sophistication required to address specific problems faced by the individual patients, the MDACC approach is one multidisciplinary care to reduce risk, improve clinical outcomes, and maximize quality of life. Another subject, anal cancer. Anal cancer. Carcinoma of the anal canal is a rarely discussed malignancy representing 1.9% of all identified gastrointestinal malignancies. It is estimated in the year 2009 that approximately 5,290 patients will be diagnosed with carcinoma of the anal canal, resulting in 710 deaths. A practicing oncologist will evaluate and treat less than one such patient per year. The majority of anal carcinoma arises within the mucosa of the anus and are of squamous cell histology. Traditionally, 74 to 90% of carcinomas of the anal canal are cured with the combined modality of chemoradiation, reserving an abdominoperineal resection for salvage therapy as a consequence of its exceptional response to multimodality treatment and its infrequent presentation. Few clinical studies on carcinoma of the anal canal have been completed. Furthermore, the majority of the studies that have been recently completed are often small single institution studies. Little has changed over the past 3 decades, resulting in minimal modification in the treatment approach. Hence, the ability to redefine the standard of care of these patients exists. This chapter focuses primarily on the histological and current treatment of squamous cell carcinoma of the anal canal and the potential innovative strategies that lie ahead. Recent epidemiology, recent recent population-based analysis of the National Cancer Institute surveillance, epidemiology and results SEER data between the years 1973 and 2000 reported a steady overall increase of anal canal cancer in the United States, with this increase more pronounced for men, whereas men previously had lower incidence rate than women. The gender difference in the annual incidence has normalized, with similar rates demonstrated at 2.04 per 100,000 for men and 2,000.06 per 100,000 for women. There has been an overall increase in the rate of in situ disease from 0.09 to 0.45 per 100,000 persons, surpassing a less pronounced increase in the rate of invasive disease, with more advanced disease stage inversely associated with overall survival. These disparities exist in particular for black men, who exhibited a 2.5-fold increase in the incidence rate from 1994 to 2000, and with black patients overall having a consistently higher mortality, with a poorer stage-specific relative survival at 5 years when compared with white patients. Especially high incidence of anal cancer has also been seen in the population of men who have sex with men and patients infected with human immunodeficiency virus, HIV. Etiology: multiple risk factors have been associated with the development of carcinoma of the anal canal. Early studies implicated chronic inflammatory bowel disease such as ulcerative colitis and Crohn's disease in the development of anal carcinoma, but recent large population studies have shown these conditions don't predispose patients to a higher risk of developing anal cancer. Benign conditions such as hemorrhoids, fissures, and anal fistulas have also not been determined to the causal factors. Rather, it has been postulated that these benign conditions may instead represent the initial symptoms of anal cancer. Human papilloma virus, human immunodeficiency virus, chronic immunosuppression, tobacco use, sexual activity. The pathogenesis of developing anal cancer is largely related to sexual practices as well as history of genital viral and bacterial sexually transmitted infections. Common risk factors associated with anal cancer include a history of more than 10 sexual partners, representative anal intercourse, receptive anal intercourse before the age of 30, and sexually transmitted disease including condyloma, acuminata, genital warts attributed to the human papillomavirus, gonorrhea, herpes virus, hepatitis, chlamydia, trachomatis, or history of infection with Here, women with history of cervical, vaginal or vulvar cancer are 3 to 5 times more likely to develop anal cancer as opposed to stomach or colon cancer. Causality for the association between cervical, vaginal and vulvar cancer and carcinoma of the anal canal has been attributed to exposure to the accusation of the HPV, human papillomavirus, in the anatomic regions. Human papillomavirus is the most common sexually transmitted disease in the United States, affecting 20 million Americans and has been strongly associated with the development of anal carcinoma. Chronic immunosuppression, solid organ transplantation has been associated with 10-fold increased risk of developing anal cancer and 20-fold increased risk of vulvar and vaginal cancer. Renal transplant recipients appear to be increased risk for developing human papillomavirus, which may place these patients at greater risk for anal cancer relative to those receiving other organ transplants. Tobacco use. Prior case control studies have indicated chronic tobacco use may result in 2 to 5-fold increased likelihood of developing anal cancer. A Danish and Swedish case control study found an increased risk of anal carcinoma among premenopausal women who currently smoke tobacco. Staging, treatment, surgery, radiation as single modality, chemoradiation, some chemotherapeutic agent, adenocarcinoma of the anal canal. Anal adenocarcinoma has been reported to represent 16.5% of all anal cancers. However, most of the reports overestimate the incidence of adenocarcinoma of the anal canal because they don't exclude contamination by the more common distal rectal cancer. The true incidence is likely less than 10%. Its etiology remains unclear, but like its squamous cell counterpart, it has been linked in the past of chronic inflammatory condition and human papillomavirus. Yes, another subject, neuroendocrine tumors. Neuroendocrine tumors originate from neuroendocrine cells located throughout the body. This chapter focuses on low to intermediate grade neuroendocrine tumors through the term neuroendocrine tumor also denotes diseases such as small cell carcinomas of pulmonary and extrapulmonary origin, thyroid medullar carcinoma, neuroblastoma, and Merkel cell tumor. Islet cell carcinomas, also known as pancreatic endocrine tumors, pancreatic NETs, or pancreatic carcinoid, rise from the islet of Langerhans low to intermediate grade. NETs rising from other sides are generally called carcinoid and are localized most often in the gastrointestinal tract or bronchopulmonary tree. These tumors share the capacity for hormone production and usually have an indolent clinical course, presenting symptoms when present are caused by excess hormone as local tumor growth and or metastasis. Surgical resection is a curative approach for localized disease. In unresectable and or metastatic disease, long-acting somatostatin analogs such as octreotide have significantly improved quality of life. The roles of newer targeted agents are under investigation in the phase 3 trials discussed in the chapter. This chapter also presents sample clinical cases from the MD Anderson Cancer Center to illustrate the challenges of the caring for the NET patient and the utility of the multidisciplinary approach. The epidemiology, the overall incidence of neuroendocrine tumor in the United States is estimated at 5.25 cases per 100,000. Most neuroendocrine tumors progress slowly and may remain undiagnosed for many years. Of note, carcinoid tumors were found in 0.65 to 1.2% of patients during unselected small intestine necropsy. These tumors are usually diagnosed in the 6th and 7th decades of life. Neuroendocrine tumors have been described as more common among African Americans owing to higher diagnosed incidence of rectal carcinoid. The gastrointestinal tract is the most common primary site of neuroendocrine tumors, accounting for 58% of all carcinoid tumors. The distribution of neuroendocrine tumors is illustrated. Clinical presentation. The classic symptoms associated with hormonal overproduction in carcinoid syndrome, such as flushing and diarrhea, are typically present in the setting of metastasis. These symptoms can be insidious in onset and present years before diagnosis. Symptoms of local and regional carcinoid and islet cell carcinoma disease, with the exception of hypoglycemia in insulinoma, tend to be vague symptoms, often occur as complications. or acute obstruction from primary tumor mesenteric fibrosis or ischemia secondary to mesenteric vascular involvement. Multiple diagnostic procedures are typically including computer tomography, abdomen and pelvis, esophago, gastroduodenoscopy, and colonoscopy, sometimes without achieving a diagnosis. Different short article: carcinoid clinical behavior visite, gastric carcinoid, small intestine carcinoid, appendiceal carcinoid, rectal carcinoid, insulinoma carcinoid, gastrinoma, somatostatinoma, lipoma, glucagonoma, pancreatic polypeptidoma, and so on. More less important subject. And I would like say something about conclusion. The multidisciplinary approach of effective, efficient diagnosis and treatment of both localized and advanced neuroendocrine tumor is paramount. The care of patients with localized neuroendocrine tumor disease requires the expertise of both the surgeon and the pathologist. The patient with advanced neuroendocrine tumor present in physician with different challenges and interventional radiologists, in addition to medical oncologists, have a role to play in symptom control. Unfortunately, the options presently available to the medical oncologist to halt or prolong the natural history and advance neuroendocrine tumor disease are currently limited. However, several ongoing phase 3 trials address the effectiveness of newer and promising targeted therapies in the delaying the progression of disease in advanced neuroendocrine tumor. Specific targets include vascular endothelial growth factor, bevacizumab, the vascular endothelial growth factor receptor, sunitinib, and mTOR, everolimus. Notably, the clinical utility of several targeted agents is being evaluated both as a single agent therapy and in combination with depot octreotide. Furthermore, the potential of somatostatin analogs alone to alter the natural history and advance neuroendocrine tumor is the subject of ongoing clinical investigation. This research will, we hope, produce an evidence-based strategy, possibly employing targeted therapy and or somatostatin analog to prolong overall survival in patients with advanced neuroendocrine tumor. That's all this program. Public health education, broadcasting, and next program subject is breast cancer. I hope we will join us together next program. Thank you so much. Thank you very much. Your patience See you later.